Just give me a few minutes. All right. So you're going to allow me to share my presentation.
Yes, Doctor, you have the sharing rights.
Okay. Are you able to see the screen, the slides?
Yeah, clear, Doctor. You just need maybe to enlarge them, but they're okay.
Okay.
Perfect.
All right. Thank you so much, members of the SOGA Forum. Those who don't know me, I can briefly put on my video so you can see me. Yeah. Sorry, I'm still in consultation room. But my name is Henry Ddungu, and I'm here as a hematologist and also as president of the Hematology and Oncology Society of Uganda. So I'm a senior consultant in hematology and oncology based at the Uganda Cancer Institute. But right now, I'm doing this from Lee Memorial Hospital. I can switch off my video so that at least we don't have challenge with network. Venous thromboembolism is the term we are going to use. But the moment we say venous thromboembolism, you know that we mean a combination of deep vein thrombosis and pulmonary embolism. I suppose that at the end of this session, we should be able to really get a bit of understanding of the pathophysiology of venous thromboembolism and the rationale for treatment. We should be able to describe the role of diagnostic strategies, including the pretest probability assessment, D-dimer assays, and if we have time, we can discuss openly on the role of compression ultrasound scan and venography. We can also have a discussion on the treatment recommendations based on the most recent guidelines from the American Society of Chest Physicians, and also any other treatments that we may discuss during the discussion. For sure, we cannot finish everything VTE in 1 hour, but at least we can have time to discuss some of the common questions people have. Okay, so venous thromboembolism is a general term for pathological venous thrombosis with the potential for embolization to the pulmonary circulation. Although thrombosis can develop in any vein, more than 90% occurs in the veins of the lower limbs or the leg. And venous thrombosis in the leg is classified as either superficial, if it involves only the superficial veins, or deep, if it involves any of the visceral venous system of the leg. And when it gets to deep vein thrombosis, it is further classified based on its location. And this is a simple classification. It is either distal, which means it is confined to the veins below the popliteal vein. If you're sitting and you can put the hands under your knee, and anything above the knee will be taken as proximal. This is the simple anatomical location. If we look at, say, the right leg, to show us the areas that are commonly seen. You look at the femoral vein around here, and then we have the superficial circumflex iliac, we have the superficial epigastric, so if you get a clot forming around this opening, just know it is a huge clot because it's forming in a major, vessel. Then when it comes down to the greater saphenous veins, it comes down to the popliteal area here. So all these areas can be affected by a blood clot. Okay. So, okay, in terms of pathophysiology, I think you all remember the virtual triad where we talk about hypercoagulability, stasis, and vascular injury as the main drivers for blood to clot, for your blood to clot. We have to remember that the coagulation system is highly regulated to reduce the likelihood of pathological clotting, but also to reduce on the likelihood of bleeding. So it is highly regulated to make sure that blood is always in the flowing mood and not to clot during its way to wherever it's going. But when clotting occurs, it is usually attributable to one or more of these factors that I talked about. One of them is venous stasis. And you can think of it in any ways where you have blood in the vessels not moving properly. The issue of hypercoagulability, there are situations where one's system is in a state of hypercoagulability. For example, pregnancy, or if you have an inheritable factors that make your blood clot sooner than other, what we call thrombophilia. And then in situations where you have vascular injury, including injuries as a result of dyslipidemia, you have a lot of cholesterol, or actually physical trauma to the veins. So all these can contribute to why one can get a blood clot. And if you have to think about it, venous stasis, hypercoagulability, and vascular injury, these are the main drivers of having a blood clot. Can you guys hear me?
Yes, doctor, we're hearing you.
Okay. So DVT rarely occurs in the absence of these risk factors I've talked about. But the most common risk factors that I can remind you of are the usual things: surgery, having cancer, being immobilized for whatever reason. For example, you are in hospital and maybe someone has a paralysis on one side and you are not able to move your limbs. It puts you at risk of getting blood clot, because we said whenever you're in a situation of impaired mobilization, blood is not flowing, it will clot. It's like when you cut chicken and put blood in a container. That container that has no anticoagulant, eventually you find that blood has clotted. So trauma, pregnancy, use of estrogens and others. But there are also some congenital causes of DVT, such as, when you have factor V Leiden mutation, the prothrombin gene mutation, and reduced levels of protein CS and antithrombin. So when you have those, then you are in a situation of hypercoagulability. But there are other factors that can lead to cause of DVT, states that are either congenital or acquired. For example, hyperhomocystinemia, elevated levels of fibrinogen or forms of dysfibrinogenemia, and then elevated levels of clotting factors 8, 9, and 11. These are known to be associated with thrombosis. So the time when we talk about transient risk factors, there are some strong transient risk factors, such as, for you, the surgeons, you talk about hip or leg fracture, hip or leg joint replacement, major general surgery, major trauma, spinal cord injury. These are strong risk factors that increase one's risk of getting a blood clot. And then we have those that are taken as moderate risk factors. For example, arthroscopic knee surgery or cancer, central venous lines, congestive heart failure, hormone replacement therapy, and a number of others. And then we have the weak risk factors, such as bed rest for for about 3 days or more than that, immobility due to sitting. Some of you sit in office for a very long time, and I've seen doctors who no longer stand up to examine patients. They sit and sit and sit looking at their computers. Increasing age, and then obesity, of course, pregnancy. And sometimes if someone has extensive varicose veins, they might be associated with thrombosis. Again, I will encourage you, if you have any question that you think you should talk about, please note it down, such that in the end, we are able to talk about this. But how aggressively should we look for the cause. Okay, this is a question that has come several times. People coming to you and they're like, doctor, they said I have a clot. How much should I do? So testing for hypercoagulable states is only indicated if it will modify management. You who are seeing patients, don't put your patients on tension because they have a blood clot and you want to make sure you confirm why they got a clot. You should test for hypercoagulable states if you know it's going to modify management. It is not indicated in cases of secondary DVT, and it is not indicated in fast unprecipitated DVT in a person over 60 years. There's no need why you should hustle so much to look for the cause of a clot. It may be indicated in idiopathic fast DVT in those who are younger than 45 years, and in those with recurrent DVT or DVT in an unusual location, okay? And if you have questions about these unusual locations, I'll happily talk about them. If one has DVT occurring in the setting of a first-degree relative with DVT, and perhaps in patients with a strong family history of VTE who will be exposed to a situation associated with an increased risk of DVT. Enthusiasm for hypercoagulability testing has been tempered by the observation that the common states predisposed to fast but not recurrent VTEs. So presence of the common states should not therefore influence decisions about duration of anticoagulant therapy. Those are new statements that we currently use. Now, members, colleagues, whenever we have a disease, we talk about the natural history. We now know that as a result of routine treatment of all patients with VTE, the natural history of untreated VTE is unknown. I am saying this now because I know many of you now are able to treat blood clots. The times when we were in school, people were a bit hesitant because they were scared about bleeding, and it wasn't universal. But reliable estimates for the risk of untreated VTE cannot be provided because of that. And the best available evidence in our literature is a study that was published by Barrett and Jordan in the Lancet way back in 1960, okay, where patients with clinically diagnosed PE were randomized to receive heparin or no anticoagulant therapy. So around during the time when the study was going on, and after 35 patients had been included, there was necessity to review the further conduct of the trial. And this was because the independent committee looked at the results and they found that of 19 patients who had not received anticoagulants, 5 had died of pulmonary embolism. And of 16 patients who had received anticoagulants, none had died of PE, and 1 had died of suppurative pneumonia. So looking at these results, when they did further analysis, indeed they found that the results showed that the difference in death in the 2 groups from pulmonary embolism was unlikely to be due to chance, as you can see the p-value. And actually they went further to do further analysis, and the p-value went to less than 0.000. So this showed that the observed difference was actually not by chance. And it led to establishing the need for aggressive treatment of VTE with effective anticoagulants. And the study suggested that untreated VTE is potentially lethal. No one can do such a study right now because it would be totally unethical. So how do we make a diagnosis of DVT? Here I'm speaking to people who have gone through all this, and we're just having a reminder of things. But the principles remain the same, that clinically suspected DVT should always be confirmed using objective tests to avoid needless exposure to anticoagulants. And the other principle is that recurrent DVT poses a greater diagnostic challenge and must also be objectively confirmed. And the presence of thrombus in a patient with a history of previous DVT is not diagnostic of recurrence unless there is evidence of definite new thrombus compared with prior imaging. I've seen many colleagues who worry so much because they said after 2 months of treatment or after 3 months, they repeat a scan and there's a clot. That does not mean recurrence. It means the original clot is not completely washed away. So we should be careful to not to allay, to cause a lot of anxiety among patients. Newer tests such as magnetic resonance venography have not been rigorously studied and should therefore be interpreted with caution. They should not be relied upon as a test to rule out DVT because their negative predictive value has not been established yet. Diagnosis requires clinical suspicion followed by confirmatory testing. And under clinical suspicion, a variety of validated scoring models that allow classification of patients into either low, moderate, or high risk for clot have been published. And we need to use these scoring systems so that there's rational use of objective testing and not to obviate the need for some radiological procedures. I've seen it's becoming routine. Anyone with a bit of an elevated D dimer, they send for CT pulmonary angiography. Not even doing a scan of the lower limb, but because people have access to those. So all suspected cases of DVT require some form of objective testing to rule in or rule out the diagnosis. That is what we call confirmatory testing. So you clinicians, when should you suspect DVT? I'll repeat this. Clinical features such as pain, warmth, and reddening or erythema have limited value in the diagnosis of DVT. The differential diagnosis for suspected DVT is extensive. If you look at a list of possibilities as differentials, it's enormous. So we need to make sure that when DVT is clinically suspected, a pretest probability should be determined using validated clinical prediction rules. I think many of you know about the Wells score or Wells criteria. And now we have the primary care rule. Actually, the Wells criteria, much as has been used extensively, it has certain limitations. It hasn't been validated in certain situations, such as in pregnancy and other situations. But then there's the primary care rule, as we shall briefly talk about it. But no matter which tool is used, a clinical prediction rule should not be the sole criterion for diagnosis. It should be used in conjunction with D-dimer testing to determine whether diagnostic imaging is necessary or it is not necessary. I'll keep checking to see if we are still together. You can confirm and say if we're still together.
Together with you.
Pardon me?
We're still together. I've just met the rest of the participants, but we are still together.
Good. So I said no matter which tool is used, a clinical prediction rule should not be the sole criterion for diagnosis. It should be used in conjunction with D-dimer testing to determine whether diagnostic imaging is necessary or not. Okay? Moving on, this is the common Wells criteria, where each clinical parameter scores a 1. For example, active cancer, paralysis or paresis, being bedridden for more than 3 days, entire leg is swollen. Each of those scores 1. And I think for each of you clinicians, you should have this maybe somewhere in your consultation room in case you sometimes get, patients with DVT. If an alternative diagnosis or is more likely than a DVT, for example, overlying cellulitis or traumatic injury, the person should score a -2. And then at the end, you'll be able to give a score of this. I'll show you how we put them into categories. When it comes to the primary care rule, again, here we look at predictors of DVT and weight of the indicator. For example, male gender, oral contraceptive use, presence of malignancy, or recent surgery, they all score 1. But when you have a cuff difference of more than 3 centimeters, it scores 2. And an abnormal D-dimer test result using a validated testing result. If you have an abnormal D-dimer test, then it scores 6, okay? And in the end, we are going to look at it whether we have a very low risk for DVT if the score is less than 3 or equal to 3. And if it's more than 4, then we say you're at an increased risk of having a DVT. The sensitivity of this test is quite high, and the specificity is also low, okay? But the sensitivity is high with a very high negative predictive value. And as you know, for a predictive test, we like a high negative predictive value, so that when someone is negative, it is truly negative. When it is positive, we cannot say that, yes, you have a DVT, but you can say most likely you have a DVT. We can do further tests. So under the Wells criteria, just a moment, under the Wells criteria, they are summarized to provide a score, either into high probability, where the score is more than 3, moderate probability, where the score is 1 to 2, and low probability, where the score is less than 0. So a low probability means that the likelihood of a DVT is less than 10%. And a moderate probability means that the likelihood is 20 to 50%. Whereas a high probability means that the likelihood is more than 80%. To make a diagnosis, you can read about the D-dimers, you know about it. The advantages are that it's non-invasive, it is validated, the tests have high sensitivity in selected populations, and it allows an image-free diagnostic strategy. For example, a low pretest probability and a negative validated D-dimer may obviate need for further investigation. We cannot just depend on that. It has limitations. For example, there's a lot of high rates of false positives, and many conditions, including those that could mimic deep vein thrombosis or PE, will cause the D-dimer to become positive. So a diagnosis of DVT should never rest solely on a positive D-dimer. Take an example, you have a pregnant woman and she has a D-dimer that is maybe 3 times above normal, and she's in the 3rd trimester of pregnancy. You need to understand that in pregnancy, a D-dimer can be high even when someone doesn't have a blood clot. Excuse me for a few seconds, please.
Doctor, we can't hear you.
Excuse him for some few seconds.
The network is off.
Sincere apologies, gentlemen. I got a small apologies for that. So I was saying that please do not rely only on the D-dimer to say this is a blood clot. Sometimes the wrong test is done in most centers. So reliance on a negative, insensitive test could expose patients to the risk of a missed clot. Okay? So irrespective of the result of a D-dimer, all patients with a high pretest probability must undergo objective testing. I'll not spend time on this, but CT scan has been done and has advantages that can visualize a persistent intraluminal filling defect. If you use MRV, you don't need to get radiated, and veins can be visualized that are otherwise difficult. The limitations is it's not widely available, and sometimes it's expensive and may involve contrast. So we don't use it as a routine, but at least CT pulmonary angiography is used to help confirm PE. So now when we have this general overview, I want us to look at the most recent guidelines. And I'm just picking a few questions that I think we should all look at and see if it can help us to understand this. This is a compendium, I mean, a summary of a compendium and review of the chest guidelines of 2012-2021, which is published in the Journal of Chest in 2024. We may not have time to go through all this. And which interventional and adjunctive therapies can we do? The initiation phase of treatment, the treatment phase, the extended. Complications, we might talk about them in the discussion. But the principles of treatment are that all patients with objectively confirmed symptomatic deep vein thrombosis require immediate treatment with anticoagulants to reduce the risk of proximal extension or pulmonary embolism. If someone has a DVT, they need to be treated so that the clot does not move. And that rapid anticoagulation is needed to reduce the risk. Long-term anticoagulation to reduce risk of recurrency, and we need to stop anticoagulation when the risk of treatment is greater than the risk of recurrent DVT. And here when I talk about risk of treatment, I mostly mean bleeding. I tell students that rule number 1, never anticoagulate a bleeding patient because they'll continue to bleed until when they die. So please avoid. Now let's look at the initial management of a DVT. And the question is whether to treat isolated distal DVT. And remember I said distal DVT means anything below the popliteal vein. I mean, when you look at the popliteal fossa and go down the leg, the experts say that in patients with acute isolated distal DVT of the leg, without severe symptoms or risk factors for extension, ladies and gentlemen, just do serial imaging of the deep veins for 2 weeks rather than going into anticoagulation. But if they have severe symptoms or risk factors for extension, it is recommended that you give anticoagulants rather than just observing. I don't know if that makes sense. It is, you have a clot, a small clot in the lower part of the leg, and you find it accidentally, the risk of extension is not obvious. Just do monitoring by doing scans. But if you think that the symptoms are too much or the risk factors for extension, give anticoagulation. This is when you as a clinician, you have to take these decisions. So this is a summary, and I'm happy to share with you slides later. When you look at the venous anatomy of the lower extremity and the relevant guidance statements to treat. It's a summary of the things I'm talking about, where you have isolated distal DVT around here, where you have isolated superficial DVT, and then you have proximal DVT side. So, whether to treat isolated DVT remains a question. And here the experts say that in patients with acute isolated distal DVT of the leg who are managed with serial imaging, you don't need to give anticoagulants if the thrombus does not extend. Remember, we started with serial imaging. So if you do this and nothing is changing, don't give treatment. And if the thrombus extends but remains confined to the distal vein, you can give anticoagulants. And you can also do anticoagulation if the thrombus extends into the proximal veins scans. I don't know how practical it is in Busoga and other parts of the country to be doing Moderator, are you there?
Yes, Doctor, I'm on call. I just had it drop, but I'm here.
Others who are there, tell me if you can hear me. In the initial management of VTE, the question is into pulmonary embolism. Okay. Clinical surveillance over anticoagulation. But coagulation should be considered over surveillance. Okay. So if it is subsegmental but with high risk of recurrent VTE, please give anticoagulants. The other question is whether to treat what we call incidentally is undergoing evaluation for something else. And then you find that, oh my God, they have a clot in the lungs. So the guidelines say that in patients who are incidental embolism, you should give the same initial and long-term anticoagulation. The way why this question came in, it used to be so controversial. But this patient has not been complaining. When you're doing other tests looking for, staging workup for cancer, find the blood should be treated. The evidence is, and it's strong evidence that actually you should go ahead and treat this person. I hope I'm not getting technical. Results. Because if you don't, you're going to delay treatment and the clot might extend. The other statement is that patients with an intermediate clinical suspicion of acute VTE, again, treat them with parenteral anticoagulants rather than not to treat them. And in those with a low risk or a low clinical suspicion of acute VTE, you may choose not to treat until when you get the results, okay? As long as they will be expected in the next 24 hours. So here, the message is, if someone comes to you, they have a swollen lower limb, and you look at the Wells criteria, and you think the alternative diagnosis is highly unlikely, it's not cellulitis, it's not trauma, it's not what you think, it's a clot, please go ahead and treat this person as we wait for the investigations. Now, Many of you have heard about interventional therapies in thrombosis. Thrombolytic therapy, in other words. There's a question of whether to use these in acute DVT. And here the statement is, in patients with acute DVT of the leg, anticoagulant therapy alone is recommended over interventional. What do I mean by this? Don't think that whoever has a DVT should be given thrombolytic therapy, whether mechanical or pharmacomechanical, okay? And in patients with acute DVT who undergo thrombosis removal, what we call pharmacomechanical clot removal, the same intensity and duration of anticoagulant therapy should be given as those who did not undergo thrombosis removal. So some people are thinking that if you go in and do thrombectomy, you know, now you can do catheter-driven removal of a clot. You remove it, but you still have to give anticoagulants for the same period of time. Again, under interventional and these adjunctive therapies, whether to use interventional therapies in acute pulmonary embolism. I know many of you have thought of giving, thrombolysis in patients. But here the experts say that if a patient has acute pulmonary embolism, which is associated with hypotension, that means it is severe disease, but who do not have a high bleeding risk, systemically administered thrombolytic therapy should be given. So if someone has a PE, a clot in the lungs, you know you are dealing with between life and death, okay? The pressure has dropped. Systolic pressure is 90, and they're not at risk of bleeding. Please, if you have the expertise, give systemic thrombolysis, okay? And they say that in most patients with acute PE, not associated with hypotension, systemically administered thrombolytic therapy may not be recommended because much as they have a clot in the lungs, but they're not having severe disease, they do not need thrombolytic therapy. And the reason is, whenever you give thrombolytic therapy, the risk of bleeding is very high. The need for someone to be in ICU is warranted. So if you think this person is stable, please don't do thrombolysis. And in patients with acute PE who deteriorate after starting anticoagulant therapy, but they have not yet gone into hypotension, and their bleeding risk is acceptable, please give thrombolytic therapy because it is the only way that is going to save this person. Since when you gave them treatment, they kept on deteriorating, okay? And in patients with acute PE who are treated with thrombolytic agents, the therapy should be given using a peripheral vein rather than what we call catheter-directed thrombolysis as given by the interventional cardiologists or interventional radiologists. And in patients with acute PE who are treated with thrombolytic therapy, the thrombolytic therapy should be given, as I said, in a peripheral line, yeah. But those with the PE, severe PE, who have a high bleeding risk and they failed systemic thrombolysis, or they have shock that is likely to cause death before systemic thrombolysis can take place. If appropriate expertise and if resources are available, we recommend catheter-assisted thrombus removal, okay? Because this is a patient who is dying anytime, and they cannot undergo thrombolysis. So if you can do catheter-assisted thrombus removal, which can only be done at, of course, centers that have a cath lab, that is what is recommended. Otherwise, such a person is at risk of dying of a clot. When you're initiating anticoagulation, and I'm about to finish, I have just a few more slides. In a setting of initiation phase treatment, for patients with acute DVT and whose home circumstances are adequate, ladies and gentlemen, initiate treatment at home. I mean, a person comes to you in clinic, don't admit them. They should be treated as outpatients. The rationale here is stasis worsens clotting. So if you keep someone in bed and say, don't move, you're going to worsen the clot and you're going to get more complications. And in patients with acute DVT, we encourage early ambulation. So do not tell people, hey, don't move at all. You stay in bed. They can even bring you a bedpan. Please, early ambulation is recommended over initial bed rest, okay? And this is a strong recommendation based on strong evidence. And also in patients with low risk PE, don't get worried. You can give them outpatient treatment. They don't have to be admitted. I've seen many people say, oh my God, someone has a subsegmental PE, we need to admit you for 2 weeks. And then patient leaves when they have real PE, okay? So if we are able to assess the outpatient care and home circumstances are adequate, by this I mean someone is able to be injected. If you are to giving parental treatment, then they should be treated at home. We should also look at the choice of and dosing of initiation phase if we are to use vitamin K antagonists, such as warfarin. So in patients with VTE treated with warfarin, we recommend initial treatment with parental anticoagulants, that is low molecular weight heparin, rather than no such treatment. And we also recommend early initiation of the VKAs, the vitamin K antagonists, preferably same-day treatment as you start the injections, rather than doing this later. Some people have been doing this, that they give heparin for 5 days, and then on day 6, they start warfarin. That is not the right way to do it. You need to give it concurrently, and you continue with parental anticoagulation for a minimum of 5 days, and until the INR is 2 or above for at least 24 hours. Okay? Then also whether to use and the duration of treatment, phase anticoagulation. So for a long time, we've been treating people for up to 6 months. But now there's growing evidence that in patients with VTE who do not have a contraindication to anticoagulation, please give them treatment for a minimum of 3 months. And then you can reevaluate. And the choice of treatment in this phase of anticoagulation, things have changed, and are saying that if possible, in patients with VTE, we recommend the direct oral anticoagulants like apixaban, dabigatran, edoxaban, or rivaroxaban over warfarin as treatment phase anticoagulant therapy. So I think many of you are now prescribing medicines such as rivaroxaban and apixaban that we have. But in the discussion, maybe we can talk about the advantages and disadvantages of each. And in patients with cancer-associated thrombosis, from hematology, I cannot go without talking about cancer-associated thrombosis. It is recommended that an oral activated factor 10 inhibitor, such as apixaban or edoxaban and rivaroxaban, should be given over low molecular weight heparin for the initiation and treatment phases of therapy. Back in the years, it was that if someone has cancer-associated thrombosis, the only treatment to give is low molecular weight heparin, tinzaparin or others. But now the new guidelines say if you can have apixaban, it is what is recommended. And in patients with VTE who are treated with warfarin, which is a VKA, we recommend a therapeutic INR of 2 to 3. So the target is 2.5. So rather than giving a lower INR or higher INR, and you make sure you're not going to be doing monitoring every day or every week. Sometimes you can even monitor once in a month or once in 2 months if someone has been educated properly, okay? The extended phase of anticoagulation, whether or to offer extended phase, The statements are simple, that in patients with VTE diagnosed in the setting of a major transient risk factor, it is recommended that you don't have to give extended phase anticoagulation. And in those with a minor transient risk factor, we suggest against offering extended phase anticoagulation. So you don't have to treat for very long durations of more than 3 months when actually the cause is identified and it is transient. But in those with an unprovoked VTE or VTE provoked by persistent risk factors, we recommend offering extended phase anticoagulation with probably a DOAC. DOACs are direct oral anticoagulants. And in patients with VTE and active cancer who do not have a high bleeding risk, we recommend extended anticoagulation therapy over 3 months, or if they have a high risk for bleeding, we suggest extended anticoagulant therapy over 3 months of therapy. Okay? I know there are lots of things that we need to talk about, but let me stop here so that we have at least 7 minutes of discussion. Thank you very much.
Thank you so much, Dr. Henry, for this insightful presentation. By the time we came to the end of it, there are some questions already that are in the chat. But I'll request those who can raise up their hands, raise up your hand, and I can pick on you such that you can echo out that question. William, do you have a question, Lawanda, or you just unmuted? Anyone with a question, raise up their hand. Okay, I see. Kindly unmute. I see one hand up. Kindly unmute and ask your question from Kato. Kato, you can ask that question. Unmute and ask the question. Hello, David Kato.
Hello, good evening.
Evening.
Thank you very much, Dr. Ddungu, for the presentation. My question is about whether it's acceptable to initiate patients who have pulmonary embolism, who do not have a malignancy as a risk factor associated directly on DOACs, or in this case, rivaroxaban, without any other initial treatment with low molecular weight heparin.
Okay. Do you have another question or I respond to this?
Hello, Dr. Ddungu. This is Dr. Peter Waiswa. Thank you for a great presentation. I wanted to ask 2 questions. One, could you talk about prophylaxis in deep venous thrombosis? And in which groups would you recommend it and with what? And then who should be treating these conditions? Is there a role for people in primary care? Thank you.
Thank you very much. Any other question?
Okay, can we have Martin? Martin, could you unmute and ask your question? Martin Kugoza. Okay.
Yes, thank you so much, Doctor, for the presentation. My question goes to these patients who usually have infective endocarditis. What do you have to say, Doctor, about the use of the low molecular weight heparin use?
Okay, thank you so much.
Okay, don't take on
Well,
those.
as we wait for other questions, I'll try to respond. So David Kato is saying whether we can initiate DOACs in patients with pulmonary embolism. Yes, we can, but it depends on the severity of the pulmonary embolism. As you've seen in some of the statements, if someone has a mild PE. Sometimes you can even choose not to treat, okay? But if they have PE that is not putting them into shock, they can be given direct oral anticoagulants, even when they don't have cancer. But you have to be careful about this, okay? But if they have anything to show hemodynamic instability, then they need to be treated with parenteral anticoagulants. That takes me to Dr. Waiswa's question, who should treat? You know, these are conditions that should actually be treated by the primary healthcare provider. And that's the reason why we want to raise awareness that people can treat clots. A clot may not wait for a referral. But if someone has advanced disease, then they need to be airlifted or in an ambulance into a facility that has expertise in this area. I would not say that it should only be hematologists to do this. The hematologist plays a role of guiding a general physician or a practicing physician to help them continue treatment. Prophylaxis should be given to whoever is at risk. For example, those who are undergoing surgery or those who are admitted because of stroke and they're not bleeding, they should be given thromboprophylaxis. Not everyone should be given thromboprophylaxis, but those who are at risk, especially if someone has undergone hip surgery or they have had long surgery, they should be given thromboprophylaxis. Then for infective endocarditis, it will be almost the same as when someone has mechanical valves. These are people who need to be given long-term anticoagulants. And you cannot give long-term low molecular weight heparin. Actually, the preferred is to use vitamin K antagonists, but also we can use DOACs to make sure that they're well anticoagulated. In infective endocarditis, the fear is for an infected embolus to go into somewhere and then disseminate disease. Any other question?
I will start with the question one in the chat. It is from Emmanuel Odongo Kero, who said, is it possible to get a DVT within the foot region, or it is only within the leg and thigh region? I think you just have to make a clarity on that. But then can I have Stephen Yantaro to unmute and ask your question?
Yes, thank you very much for the presentation, Doctor. My inquiry is on the early ambulation VTE, which most times I had more of keeping them bedrest, but from here I'm hearing of early ambulation. Couldn't that risk extension of the thrombus? Thank you.
Well, that's a very good question. I wonder where you find your patients, because if you find patients in their homes, then that makes sense. But most of these patients actually find you in the hospital, right? Which means they came ambulating. So the truth is almost 50% of people, by the time they come to hospital, if they have a major clot, it has moved, okay? What you have to do is to give them anticoagulants to make sure that, whatever is moving does not accumulate even more. Because the anticoagulants we are giving are not thrombolytic medicines, but they're to stop further clotting to happen. And if you don't ambulate them early, the stasis is going to lead to further damage to the valves. And when you get valvular damage in the vessels, the risk of getting post-thrombotic phlebitis or post-thrombotic syndrome is going to increase. This is when you find a person whose leg never gets small. Each moment they stand up, the leg is so big because someone told them not to move at all, and now they have permanent discomfort in the leg. So moving on to DVT in the foot, you can actually get a clot anywhere where there's a vessel. And most people have vessels in their feet. So if you have a vein in the foot, you can get a clot. But some of these clots are too small to cause clinical significance. It's like when you get a clot forming following an IV cannulation. It is a very superficial clot, that doesn't need to be treated and you don't have to worry about it. But there's some clots that form deeper into the anatomical formation of a foot that we need to look out for.
Thank you, Doctor. We take up
Yeah.
and we will invite Dr. Stephen to give a vote of thanks. We'll invite Professor Peter to close the session. Let me have Cedric and okay, one hand is up. Let me have Cedric Nantamba to make your question. You're the last person.
Thank you, Doctor, for the great presentation. My question is there any indication of these compression stockings in the management of DVT? And I wanted some comment about apixaban and rivaroxaban in case a patient presents to us with DVT and is bleeding. Thank you so much.
All right, thank you so much. So to start with compression stockings, there's actually less evidence on their utility, but some anecdotal evidence is that if you use them early, maybe they can reduce on the risk of post-thrombotic syndrome or the swelling that one gets after that. But they don't have a lot of, when you look at collected evidence, it's not that when you use them, you're going to completely get treated. And we don't use these normal compression stockings in preventing. When it comes to preventing, we want to use the mechanical pneumatic stockings that pump each other. You connect them and they pump so that they force blood to move. Apixaban and rivaroxaban, I don't know if you said if a patient came to you and they're bleeding. If someone is bleeding, do not anticoagulate them because you're going to make the bleeding worse. Apixaban is a newer version of a direct oral anticoagulant. I think it came after rivaroxaban and after dabigatran, then apixaban came in. They're both oral anticoagulants. They are not affected by food. They are not, you don't have to adjust the dose. Their doses are fixed. The only challenge with the direct oral anticoagulants is they have to be used appropriately. If someone is on rivaroxaban, for example, and they continue forgetting how to take it, their risk of getting a blood clot while on treatment is actually high. The same applies to apixaban. If you get a patient and they need to be put on these anticoagulants, you need to educate them to stick to the treatment, to make sure that they don't even miss by 30 minutes, so that at any point there's medicine in the system. But we don't use it when someone is bleeding. The advantage with apixaban, it is even in lower doses. You can even use it in certain forms of renal failure, which is not the case with the other anticoagulants. Because, for example, if someone has end-stage kidney disease or they're on dialysis, they may not be able to use low molecular weight heparin. What they can use is unfractionated heparin or warfarin if the risk of bleeding is not high. I think I'll stop here, unless if there's a question.
Thank you so much, Dr. Henry. Dr. Stephen, can you give a vote of thanks to Dr. Henry for his presentation?
Okay, yeah, thank you, Benjamin. Good afternoon, good morning, and good evening, everyone, depending on where you are. First, I would like to thank the Busoga Health Forum through Professor Peter Waiswa and Benjamin for organizing this CME session, and also to thank the participants for having joined this discussion to learn. And lastly, but most importantly, is to thank Dr. Henry Ddungu for taking us through this session. At least for us who were in the medical school for more than 20 years ago, you remember that the drugs we used to use mainly were heparin and warfarin, and we didn't know some of these new drugs that have developed. But also the clinical management based on the discussion he has provided. It's clear that while this condition can be managed in the primary healthcare setting, I think we are likely to get better outcomes if we do this in consultation with the hematologist. So I'm hopeful that even after this CME session, that Dr. Ddungu Henry will be available to provide ongoing mentorship to those practitioners who are in the primary healthcare settings, such that they're able to make very informed clinical decisions that are going to ensure that we have very good outcomes for our patients. We thank you so much, and we look forward to having you back. Over.
Thank you very much. I appreciate it.
Stephen, this SEME brought a maximum of 250 participants online. 85% were medical health workers. I want to invite Professor Peter to close the session.
Thank you so much, Benjamin. By the Dr. Ddungu, Benjamin is actually a nurse, a certificate nurse, but he runs the show at Busoga Espola. All these things you see, cheering, but also he does all these adverts. And many times when you don't get senior people to cheer, he does the needful. He's currently doing a diploma, but that is where he comes from. He's a very young, smart guy. The other asked him his age, and he's 25 or 26. So we thank you, Benjamin, for the job well done. I want to be honest, Dr. Vaveyo. I saw this advert of Dr. Ddungu. I was not involved at all in organizing it, and many of the things I'm no longer involved. Benjamin and team run the show with Moses and team there, and the other people like Dr. Omsoga. So Dr. Ddungu, we used to meet very much at the canteen in Mulago.
Absolutely.
I don't know whether you are still there for lunch. I almost stopped going there. I've not been there for ages.
But
I'm always
been there for
joining
many
you
years.
on Radio 1, where you do a very good job. Thank you for consistent over these many, many years doing so. Not so many doctors do this in educating. So I must say, as a public person, I'm very proud of you. And as you've noticed, Busoga Forum has become the #1 CME provider. We provide it to the nation and beyond. So we thank you for coming on board with a very simple and yet very complex topic. When I listen to it, I say, oh God, people in medical school now can suffer because you need to know all these complexities and yet you've not even covered the entire topic. I would like to challenge you to come up with some simple guidelines. Maybe I could say IMCI style guidelines for people in primary care. I mean, where there is this, then these adoptions, because those are the things people really need. Otherwise, they will abuse all these drugs by giving them to people, and as you said, cause more problems. Then also, a lot of your patients at Cancer Institute come from Busoga. And when you pass by, you hear them speaking all over. So it's good that you are coming to engage people here in Busoga, but also, of course, the entire nation. So I would like to invite you back on so many things, but also to bring other people. We are willing to do the mobilization and then to provide the platform so that we educate the nation. Sometimes we get as many as 300. There are times we have gone even to 700 participants. So I'd like to invite you back to do more of this, but thank you so much. And in appreciation, we give you a simple certificate of appreciation for what you've done today. Thank you so much, Dr. Ddungu. And with that, you can make any final remark, and then we close. Thank you.
Well, Professor, thank you so much. And thank you for the great memories. I appreciate the certificate, but I also want to let you know that now that I have this opportunity to speak to the Busoga Forum, Health Forum, we have the Hematology and Oncology Society of Uganda, and we are so happy to have associated with you. We want to, take on this challenge of coming up with easy-to-use guidelines, and I think as a society, we'll be able to come up with these guidelines that we can share with everyone who is interested in taking care of people with blood disorders, including venous thromboembolism. Thank you so much.
Thank you, Dr. Andy. I don't want to make this long, but what you said is what I challenged even people like Dr. Nakwaga and others, Dr. Ravi, that for primary care, we just need some simple guidelines for people around these NCDs and other conditions. And I was happy when I saw you launching this group for hematology and the other stuff. Thank you so much, members. See you next Friday. Some of you have been asking, how do you get the presentation? This is going to be on YouTube. So Dr. Ddungu, this will be accessible on YouTube, I think, by Monday. And people, you can share it and people can listen to it more and more times. Thank you, colleagues, and have a good evening. Have a nice weekend. And turn up tomorrow to listen to Dr. Ddungu on Radio 1. Dr. Ddungu, is that 10 or 9?
Talking about cancer of the cervix tomorrow.
Okay, cancer of the cervix tomorrow at on Radio 1 at
Radio 1, 9 o'clock.
At 9 o'clock. Thank you, and bye-bye.
Bye-bye.